welcome to the Walter and Eliza Hall Institute, where Ovarian Cancer Australia are running a Q&A session for women who've had a diagnosis of ovarian cancer and their family and friends. And we've had hundreds of questions from across Australia, and we've then invited clinicians and experts, researchers who have the answers to the questions. And so let's go. It's my great pleasure to welcome now Associate Professor Alison Trainer. She's a consultant clinical geneticist at what is now called the Peter MacCallum and Royal Melbourne Familial Cancer Centre. Would you please make her welcome? Just before we begin, just tell us the primary focus of your work and also the significance of that change in the name of the organisation.
Yes, thank you. The change is today's quite an auspicious day. It's the first opening of the Victorian Comprehensive Cancer Centre building, and the patients are moving in as we speak. That means that the two familial cancer centres, which were initially separate, based at the Royal Melbourne and the Peter MacCallum, have now joined and formed one of the largest familial cancer centres, certainly in Victoria. And then patients will be seen both in the Victorian Comprehensive Cancer Centre building, which is that beautiful building as you've seen as you've walked across, as well as in the Royal Melbourne part of the clinical service.
What is genetic testing? Where do you get it and what does it cost?
Genetic testing covers a great scope of different diseases. It's not just familial cancer, but if we concentrate on the familial cancer, it is a service, it's a clinical service. Often people think that what we're offering is research. We do offer research, but the majority of patients we've seen are seen due to evidence-based clinical referral guidelines and management guidelines. Anybody can be referred, you can self-refer. We as are based in a public hospital, bulk bill our patients, so there's no out-of-pocket cost for the appointments. If you self-refer, we will ask you to provide a GP referral so that we can bulk bill. We identify families that have got an increased risk of underlying cancer syndromes, not just breast and ovarian, but colorectal, thyroid, parathyroid. There's many different types of familial cancer syndromes. If we focus on the ovarian cancer syndromes, we see families, we assess what the likelihood is that you have an underlying genetic fault to account for the family history or indeed your own personal history, and we'll offer the appropriate testing. The testing itself is publicly funded if you fulfill the national guidelines, and that's paid for at the state level. At the moment, there's no Medicare funding for genetic testing. It's something that we're all at the moment very much trying to arrange and orchestrate, but at the present it's state funded.
So who should get it? And then what are the pros or cons of getting it? You know, what's the impact on the individual with that information they receive?
I think the first thing to say is we'd be keen to see anybody with a strong family history of particularly young onset cancers. The genetic cancers tend to be younger than the normal population. So anybody with a strong breast and ovarian cancer history. I should say here though straight away that any woman who has a high grade serous ovarian cancer, so that's about 75% of women who get diagnosed with an ovarian cancer, we would offer you testing irrespective of your family history. So even if you're the first person in the family to be diagnosed with an ovarian cancer, if it's a high grade serous, you should contact us and we would happily offer testing to you. The reason we offer testing, and we live in very interesting times, first of all, it would allow us to assess any additional treatment that may be beneficial to you. We know that certain BRCA-related ovarian cancers can respond quite well to PARP inhibitors, and I'm sure that this is discussed in earlier sessions, and that there is funding available to help fund access to the PARP inhibitors for women with ovarian cancer. So first of all, the first reason to come for treatment is it may offer different opportunities for your oncologist to think about management. The second is to try and assess what the risk is to your relatives. If we offer testing and we identify a mutation, that is a fault, in the genes, either BRCA1 or 2 or a few of the other less common genes, we'd then be in a position to offer that test looking for that specific genetic fault to other family members to assess their risk and help them manage that risk.
Can you tell us what genetic mutations can you have and what do they mean? And I guess I'm focusing particularly on this area of ovarian cancer.
I think the first thing to remember is that we all have genetic variants. So we all have the same genes, we all look different because there is a normal variation. That just is what is underlying evolution. So to have variations in your gene is very normal. The large majority of these variants are totally benign. Currently, what we look for are the rare variants which actually stop the protein that's produced by that gene functioning. And therefore, if we can find a variant which we call pathogenic, in other words, it stops the gene functioning, we can then offer that as a test to other family members. In a few cases, in around 5 to 8% of individuals that we test, and we always test somebody with a cancer in the first instance, we'll identify a variant that we're not clear whether it's actually the cause of the condition or not. And we call those unclassified variants. In other words, or variants of uncertain significance. There's a degree of uncertainty whether they're the cause of the underlying cancer or not. And there's a whole international group of research who are working on classifying those. And in those situations, we aren't able to offer a test to other family members until we're clear whether it's the cause of the cancer or not.
When you said we live in interesting times, what do you mean?
I mean, in the past, a lot of the genetic testing has been done to try and assess the risk to other individuals in the family who are well, to try and work out what their future cancer risk can be. And in the last few years, particularly with the predominance of the PARP inhibitors, the clinical trials look very positive. We're now at the stage where your genetic test will actually affect your treatment. If it's breast cancer, women who have genetic faults often consider having bilateral mastectomies rather than a unilateral mastectomy. And in ovarian cancer, women are now having the opportunity to be recruited to PARP inhibitor trials. So whereas before it was risk prevention for healthy women, we're now turning it into management options for the woman who actually has the cancer at the time.
Now, I know we've heard now from 2 people about PARP inhibitors, but I always feel I need to hear things approximately 12 times before I understand them. So I hope you bear with me when I say, just remind us what a PARP inhibitor is and why it's such good news in the cancer front.
PARP inhibitors are drugs that work specifically in blocking a method of DNA repair. So we know that the BRCA1 and 2, they're involved. We all have breaks in our DNA, so we're constantly having to repair them. That's not unusual. And the BRCA1 and 2 are involved in a very specific form. It's called homologous recombination. It's just a very sophisticated way of repairing a break, if you think of it in a piece of string, such that there's no damage accumulating. The non-homologous joining is a bit like tying the 2 pieces of string together, and that knot can cause some problems. But if your cells have lost the ability to use their BRCA1 and 2, then they rely on this less sophisticated method. And what the PARP inhibitors do is they stop that less sophisticated method. So in other words, you can't repair those breaks and the cell dies. And of course that's important because in a woman who has a fault, it's only her tumour that has lost that DNA repairability. So it's only the tumour that's susceptible to the PARP inhibitors, which means these drugs have, they do have some toxic effects, but they have much less toxic effects than the large majority of chemotherapy agents. And they're specifically honed at cancers that are developed because of a loss of BRCA1 and 2.
Are there any other current research results or things that are just on the horizon that you think would be of interest to these women who've had a diagnosis in their families?
I think the other major finding, and again it's a very much a local finding, is by Professor Lindemann here at, in fact, the WEHI. Had a paper out in Nature which came out on Tuesday, which was highlighting that he has got a rank ligase inhibitor. It's a drug that's normally used in clinical practice, therefore we've got a good knowledge about how it works. And it seems at the moment to look very exciting as a method of reducing particularly women who have BRCA1 mutations with developing breast cancer. So we're moving into a field where we're developing drugs to stop women developing cancer in the first place, which is obviously the best way to reduce cancer incidence. So I think that work, which is very new, it's getting a lot of international recognition, and it's lovely that it's homegrown Melbourne. If it pans out, and humans trials have started, and I know that Professor Lindemann is recruiting to human trials here through the Royal Melbourne Familial and Peter Mac. If that holds out, that's going to be a major breakthrough, I think, in the future.
The reference to WEHI, I think it is, Walter and Eliza Hall Institute, is where we're sitting right now in Melbourne. And I'm talking to Associate Professor Alison Trainer. People will be watching this potentially all over the world in reality once you're on the internet, but certainly across Australia. The service that you offer in terms of genetic testing, is that available in other parts of Australia?
Absolutely. There's familial cancer centres in all of the states in Australia, and therefore the same service should be offered across all the same states. As I said, it may vary slightly in the genetic testing that you get because that's funded at the state level and not the federal level.
And the other thing I was thinking, I'm sorry, I've just gone blank on that second point that I was thinking, but it'll come back to me in a moment. Look, one aspect I wanted to talk to you about was the issue of distress and managing the emotions associated with discovering that you may have genetic mutations. Can you talk to us about that and what sort of support an individual and the family can get to manage this piece of information should they get it?
Yes, I mean, it's certainly something which we've been concerned about right from the beginning. I mean, obviously offering a test and identifying women who are at a potential risk or a future risk is very distressing. There's been a large body of work done on this. What it shows is in the moderate and the long term, people's stress levels come back down to where they were. And we know that that is common in many aspects of our lives, that we adapt to bad news. We just take it on board. The important thing, I think, to recognise, and I think it's not only is it good for the patient, it's also good for the clinician, is that we now have international studies that show that by identifying women who carry these faults before they develop cancer and managing that risk appropriately, we significantly increase their life expectancy. We decrease the risk of them dying of breast, ovarian, and in fact all-cause mortality. So now that we've got that information, we probably frame it more as empowerment in identifying something before it's caused problems. And now with also the possibility of pre-implantation diagnosis, there's means through IVF, that those women can go on and not have children who carry the same fault.
Could you explain what you just said? I'm sorry, that was a new one to me, and could you just explain what you're referring to there?
So pre-implantation diagnosis is a form of IVF. So in other words, the embryos get fertilised outside the body. If we know what the fault is, that can then be tested in the embryos once they get to about the 8 cell stage. So that's about 3 to 5 days after they've been fertilised. A single cell is taken, it's tested. If it carries the fault, that embryo is not put back into the womb. And those embryos that don't carry the faults are putting back in the womb. This is used and available for many different genetic disorders, not just the familial cancer conditions. It does, however, come with a large out-of-pocket cost at the moment. So the technology, that's the IVF plus the testing, probably costs us around $10,000 to $12,000. That doesn't necessarily mean $10,000 to $12,000 per pregnancy, because it may be that you'd get more than one embryo and therefore you may get more than one pregnancy out of one round of IVF.
Look, thank you. We're just at the end of this section of our interview, and I wondered if you could tell us, if you're sitting here and you've never spoken to your doctor or any other member of your clinical team about genetic testing, well, what other questions women need to ask their doctor about this if they wish to proceed and investigate the possibility?
I think if you're a woman who's been diagnosed with an ovarian cancer, particularly if you know if it's a high grade, then the question you want to ask is, where is my local familial cancer clinic? Full stop. You should be referred. If you're someone who has a family history of that, and unfortunately the individual has deceased, it is probably still worth coming to see us. It's more difficult in that setting to offer testing, but it may be available. At the moment, we're trying to work on the technology to be able to offer testing from paraffin sections of tumours that are stored. Large majority of pathology departments hold on to the pathology, and obviously anybody with a diagnosis needs to have that tumour looked at by a pathologist. And if we can access those tissues and arrange testing on the DNA we extract from that tissue, then that will open up testing to a much larger group of women. Because obviously we know that from the point of view of ovarian testing, we've really only been actively trying to recruit women over the last 2 to 3 years, and there may be many women who preceded that.
Look, thank you very much. Would you give Associate Professor Alison Trainer a round of applause?